The topic for today is longevity medicine in general and what actually works within longevity medicine. It is the second in a series of talks on longevity medicine. Last time we went over health as a foundation of wealth, and we'll kind of continue that theme. When I think about longevity medicine, it really is a paradigm. So we think about the foundation being lifestyle medicine. And so these are things like exercise, nutrition, sleep. I'll go into that in a little bit more detail. That really, like I say, is the bedrock. That's what really moves the needle when it comes to health and longevity. We'll talk about prevention also. So that lifestyle medicine foundation and prevention, there's a lot of overlap, but there are a few things that stick out within the underneath the umbrella of prevention that are unique and not necessarily related to lifestyle medicine. We'll talk about screening protocols and the importance of those, and then also targeted treatment, both for diagnoses, but also start to think about treating risk before it becomes a diagnosis. So lifestyle, again, the foundation of longevity. So the choices that we make today are really potent tools for extending our health span and lifespan. And number one is exercise. I like to call it the most potent longevity drug because it really is. It activates all of those physiologic systems that are important for health and well-being. I like to encourage people to kind of define your future self and figure out how to get there. The number one tool is going to be exercise. Keep in mind that age-related decline really is a reality. And so what we do today can attenuate that decline. But it's important that we're proactive in what we do to attenuate it. We have quantifiable mortality reduction tools. So exercise and how it improves our VO2 max can really measurably impact what we anticipate happening as we grow older. Movement is immensely powerful, very important to keep in mind. And then there are some key exercise modalities that we'll talk about here. What are those? Zone 2 training. So this is your foundation when it comes to exercise. Zone 2 training is exercise where you're working hard enough that it might be a little challenging to have a conversation while you're doing it, but you could. Most of our time exercising is spent there. It's important to mix in some high-intensity interval training, strength training, and also stability and mobility work. And these four aspects to your exercise program are really going to move the needle in terms of your health and well-being as you get older. The second aspect of lifestyle medicine that is essential is nutrition. I mean, this really fuels your longevity. We like to have a solid, scientifically based foundation. We like to think about principles for nutrition rather than specific diets, and focus on diets that impact our metabolic health. So when I talk about prioritizing metabolic health, these are diets that impact our insulin sensitivity, our lipid profiles, our glucose profiles, as well as our weight. But weight is not the only thing that's of importance here. Mediterranean eating patterns are known to be beneficial. It's important to prioritize protein intake, about 1.6 grams per kilogram of body weight, protein intake daily. Really minimizing ultra-processed foods. These are associated with morbidity and mortality, cardiovascular disease, diabetes, and accelerated aging. Emphasis on fiber and healthy fats, and prioritizing whole foods. These are good strategies to optimize your nutrition. And then lastly, kind of rounding out the idea of lifestyle medicine, sleep, management of stress, and maintaining good social connectedness are essential. 7 to 9 hours of sleep at night. This is when our body repairs, boosts our immune system. It's good for our cognition, reduces our mortality risk. Stress management through mindfulness, emotional regulation, builds resistance, lowers inflammation, and social connectedness is really associated with improved longevity and reduced mortality. Loneliness and social isolation are directly related to increased morbidity and mortality. So prevention, again, lifestyle medicine and prevention really do overlap. But prevention does sort of have some unique characteristics and aspects that I want to touch on. Part of prevention that's not necessarily lifestyle medicine includes things like detecting risk factors and mitigation. So an example would be a colonoscopy. So we oftentimes will lump colonoscopy into screening, but when we talk about removal of precancerous polyps during colonoscopy, I mean, that really is prevention. That's identifying a risk, the polyp, and removing it, thereby preventing cancer. So you can think about colonoscopy from that perspective. I would include things like dental care here also. It's a procedure, it's prevention, and of critical importance also. We can also talk about some risk stratified interventions, things like prophylactic surgery, say for somebody who's at exceptional risk for breast cancer, or pharmacogenomic testing to make sure that people are not taking medicines that don't work for them or are not taking medicines that could be harmful to them. Lastly, we also think about things like targeted prophylaxis and mitigation of risk. This would be through vaccinations or specific medications, say if you're traveling to a malaria endemic country, taking malaria chemoprophylaxis is a good example. This really is prevention, but from kind of a different perspective than when we are thinking about lifestyle medicine prevention. Screening. So this is the next aspect of what really works in lifestyle, in longevity medicine. And we're moving beyond just the annual checkup and the standard things that are typically done, and tailoring it to people's unique biology, individuals' unique biology. So I think about this in a few different buckets. One is thinking about body composition and functional testing. The next is looking at biomarkers or lab testing. And the last is imaging. And so this encompasses things like screening MRIs and DEXA scans. So to elaborate on some of these ideas, so DEXA scanning is really helpful for us. It's the gold standard when we're looking at body composition. So the modality is X-ray, and it's extremely low dose. It allows us to look at bone density, muscle mass, and body fat composition. It's much more helpful than just looking at somebody's weight, and it gives us much more detail than some of the advanced scales that we have that use like impedance metrics to estimate these things. So by obtaining a DEXA scan annually or more frequently and following it over time, we can pick up things like the development of osteopenia before it becomes osteoporosis. we can identify those people who have excessive visceral fat, meaning fat deep in the abdomen, as we know that that's more risky than other locations of fat. And we can track this over time. We can track if our interventions are being helpful in terms of our body composition. In terms of functional testing, one of the things that is helpful, another thing that is helpful is looking at your resting metabolic rate. So this is the number of calories your body burns while at rest. It's measured using indirect calorimetry in the clinic. And it tells us exactly how many calories your body burns at rest. So we can personalize your nutrition and weight management planning and make very specific recommendations based on what your body is doing at rest. VO2 max testing is another component to longevity medicine, which really helps us to understand how healthy you are. So VO2 max testing looks at your cardiorespiratory fitness. It measures the maximum amount of oxygen that your body can consume per minute. And then we normalize it by sort of scaling it to your body weight. So if you have a good VO2 max, that means that multiple systems within your body are working. So your heart is pumping efficiently, your lungs are moving air efficiently and exchanging oxygen and carbon dioxide. Your peripheral vascular system is moving blood and nutrients to and from muscles. It means within the muscles, your mitochondria are dialed in and working efficiently. And the higher your VO2 max goes, the more efficient those systems are. And in particular, the more efficient your cellular metabolism is, which is where that oxygen gets used. But as you can imagine, in order to hit a really good VO2 max, you have to be cognitively sharp. So you need to be able to understand the test and complete the test. You need to have reasonable muscle mass and strength, reasonable coordination, good heart health and lung health, and not have an injury. So while it measures, while the number itself measures how much oxygen you can burn per minute, it really is a surrogate for other aspects of your health and functional well-being. And so that's why we really like this. We know that you require around 20 to 30 milliliters per kilogram of oxygen per minute that's the minimum VO2 max to be able to do your activities of daily living. When you drop below 30 and start getting closer to 20, you're really going to be impacted with your activities of daily living. You're going to need help. You're going to have difficulty doing things like your laundry or climbing the stairs, cooking, cleaning, things like that. You're going to become dependent on other people. We also know that there's about a 10% decline in your VO2 max per decade. So if you're starting in your 30s or 40s with a low VO2 max because you don't exercise, you can predict that by the time you get to your 70s or 80s, you're going to have significant difficulty. And so by knowing this number, we can inform people about what their trajectory is going to be if they don't make change, or we can confirm that people are really on track and encourage them to continue what they're doing. When we think about labs, sort of moving away from the imaging and moving away from the functional testing and thinking about laboratory biomarkers, there's a collection of things that are really helpful. Some of these are done with your traditional annual visit, but I think those tests need to be expanded to make sure that we're screening for a broader range of potential problems. It's important to look at people's metabolic health by measuring their fasting insulin and looking at their insulin resistance. It's important to look at inflammatory markers, both specific to cardiovascular health and more generally. It's important to look at your cardiovascular risk. So thinking about your lipids, doing advanced lipid panels, looking at your homocysteine, et cetera. And then also looking at things like hormones. So really a comprehensive laboratory panel is very helpful for us in terms of the screening that we need to do so that we can make targeted recommendations that are effective. Just a little focus. So one screening modality that's not frequently used but is easy to do and I think of great utility, again using this as an example, is the home IR. And so this is looking at your insulin resistance. And so what we do is we don't just get a fasting glucose, but we get a fasting insulin level. And this helps us to understand if you're somebody who is, you might say, pre-diabetic. So this is looking for dysfunction at the cellular level before somebody is diabetic and has problems with blood sugar management, before somebody is pre-diabetic and having problems with insulin, with maybe their blood sugar running slightly elevated, before you see an abnormality in their hemoglobin A1C. This is really early on, and we can detect it, and we can make recommendations to help people steer clear of being, frankly, pre-diabetic or developing type 2 diabetes. The advanced lipid panels or profiles that I mentioned briefly earlier. So two really essential tests that we need in order to properly risk stratify people in their cardiovascular risk are the ApoB and the lipoprotein A tests. So historically, when we think about getting our lipids measured or our cholesterol, we'd look at things like your LDL and your HDL, triglycerides, et cetera, but really a limited panel. But we know now what subsets of our lipids really are atherogenic, or meaning really are the ones that cause cardiovascular disease. And those are the lipid particles that have a signature protein on the outside that's called apolipoprotein B. So we can quantify that we can very clearly measure the level of ApoB containing particles, and we know the range that is safe and the range that puts people at risk of cardiovascular disease. Similarly, lipoprotein A or LP little a containing particles are a subset of the ApoB containing particles, and those are about 10-fold more atherogenic or more likely to cause cardiovascular disease. So it's essential that we know what these numbers are. You could have a reasonably decent looking standard lipid panel, but have an elevated ApoB, and that's somebody who may end up requiring treatment for their lipids despite the normal standard lipid panel. A little bit more about lipoprotein A. So this is a heritable risk factor. There's not a whole lot that people can do to move the needle in terms of their LP little a number, but we know if it's elevated, they are at increased risk. Currently, if somebody has an elevated LP little a, we step up our interventions to modify all of their other cardiovascular risk. There are some medicines that will slightly decrease the LP little a, but it's not that effective. Over the next year or so, there are medications coming to market that will target LP little a and drastically reduce it. So I'm looking forward to that being an option for people who have this abnormality, this heritable abnormality in their lipid profile. And it's important that we identify those people who have it so that we can get them on treatment as soon as it becomes available, and as well as modifying their other risk factors. Other lab tests that are really helpful, looking at multi-cancer early detection testing. So Exact Sciences here in town has just come out with a product. The product that I've historically used is called the Gallery test by Grail. This is what we call a liquid biopsy. And so what these tests do is you have a standard vial of blood drawn, and then they analyze it, and they're looking for DNA that is associated with different cancers. If you think about all the cells in our body, they all turn over at a certain rate, and all the components of those cells get recycled, and that includes DNA. If you think about cancer cells, they turn over at an even faster rate. And as they turn over, some of that DNA that has a methylation signature specific for that type of cancer can get picked up in the blood. And so that's what they're testing for. Now, these tests are not meant to be primary screening modalities for cancer. It's essential that people do all of the other things for cancer screening that are important. So colonoscopy, mammography, PSA, etc. But this adds another layer of detection. I think they're about 60% sensitive for cancer. So meaning if somebody has a cancer, you're about, if you take all comers, about 60% likely to detect it. But it's about 97% sensitive or specific, meaning the false positive rate is quite low. The things that increase the sensitivity of this test or make it more likely to detect a cancer are if somebody is further along in their cancer diagnosis, simply because there's more tumor burden to release the biomarkers that can be picked up with the test. So as people get older, 50 plus, I think this is an important test to add on to supplement the other cancer screening and other diagnostic and other health screening testing that we're doing. And this just kind of elaborates on what I had mentioned earlier regarding this test. When we're talking about genetics, I also like to look at epigenetic testing. So this is testing that looks at, again, the methylation pattern on DNA and helps us to understand what somebody's biological age is as opposed to their chronological age. This being helpful in terms of understanding what somebody's overall health is. Though in reality, if somebody's biological age is older than their chronological age, I'm going to tell them to do the things that I'm going to tell them to do anyway, which is exercise, eat right, sleep, etc. But it is interesting information. Lastly, in terms of genes and genetic testing, whole genome sequencing is an option. This looks at your genome in its entirety. If you want to quantify that in terms of, in a way that's familiar. So if you get your whole genome sequence, it's about 150 gigabytes worth of information. We use this for diagnostic genetics, meaning like, does somebody have a gene that predisposes them to, say, familial colorectal cancer or breast cancer or ALS. The problems with this testing is that there can be variations in the gene that are of uncertain significance, and that can be anxiety provoking for some people. But that just means that this gene doesn't look normal, but we don't know if it's actually pathologic or if it's going to cause any problem whatsoever. The cost of whole genome sequencing, I mean, it's kind of a very broad range depending on what these companies are providing in addition to just the sequencing. But in reality, you could get your genome sequenced for somewhere around $300 these days. You can download that information onto your hard drive and using AI tools, even without much computer or programming know-how, you could actually analyze your own genome, which is really fascinating. So whole genome sequencing, it's really best for people who have, clear familial history that warrants the investigation. We talked about these variants of uncertain significance and how that might be problematic for some people, but I think this is going to become more and more prevalent as time goes on. Access to whole genome sequencing is going to become easier. The cost is going to go down. And then what we do with that information, how we interpret it, and how it informs our health going forward is really going to expand. Just a little bit more on cardiac health and screening. So when we think about cardiac health, your history is important, certainly. Symptoms are important. Labs and lipid panels are important. But then there is some specific imaging that is really helpful. So one particular modality that is inexpensive and easy to do is to get a coronary calcium score. This is a CT scan that looks for calcium deposition in your coronary arteries. The reason that calcium ends up there is because your coronary arteries, if you have coronary artery disease, will build up some plaque. That plaque is initially soft plaque, but over time it calcifies and becomes hard and can be detected on a CT scanner. Now that calcified plaque is stable and unlikely to rupture, but we think of it as a marker of coronary disease and prompts us to want to look a little more carefully for how extensive the burden of coronary disease is. For people who we have more concern about, we like to send them for coronary CT angiography. Now, with the addition of AI analysis, this helps us to quantify not only the extent of calcified plaque, but soft plaque, the density of that plaque, the distribution of that plaque, the total burden of that plaque, what kind of flow limiting narrowing there is in those coronary arteries. So it's really helpful information. We also like to use echocardiography to look at the structure and function of the heart and muscle. A little more on imaging in terms of things that are helpful. I do recommend whole body MRI screening for people. For some, this is controversial with the concern that you might have findings of unclear significance, and it might prompt testing that's unnecessary. From my perspective, those are things that can be dealt with. What I don't want to have happen is for somebody to have an early malignancy or some other diagnosis that we can intervene on and have it get missed until it's late in the course and very hard to treat. So I do have a conversation with people before I send them for whole body MRI screening to make sure that they understand what could happen if there's a finding like that. But in general, I think the information is very helpful, and on occasion you find something that's actionable and can really improve somebody's outcome. Low-dose lung CT screening. So this has traditionally been thought of as something for people with a significant smoking history. From my perspective, this is something that we should be doing on the general population, though that's not aligned with the United States Preventative Services Task Force recommendations, as you'll see here on this slide. The reason is if you look at all comers, like everybody who develops lung cancer, who is a non-smoker, and put the number of those diagnoses on a rank order list, it really falls about around like the 12th most common cancer in the country. Um, that's pretty a pretty common cancer, if you ask me. I mean, it's somewhere around like liver cancer and esophageal cancer and cervical cancer. So it's not uncommon. Um, and unfortunately, whole body MRI is not quite sensitive enough for that lung tissue. And so this is a nice addition to the other radiographic screening to pick up concerning lesions and do something about it before it becomes advanced. Other screening that I think is of significant importance is screening for obstructive sleep apnea. Sleep apnea is very common. We think maybe as many as 80% of cases are not diagnosed if you look worldwide. And it's a significant risk factor for cardiovascular events, development of atrial fibrillation, hypertension, pulmonary hypertension, and it's relatively easily treated. So again, this is a very important risk screening that I think everybody should be partaking of. So let's move from screening to precision treatment and targeted prevention. So I think lumping targeted prevention in with treatment is important because, again, going back to that, just the colonoscopy example, right? So you're taking out polyps to prevent the development of colon cancer, but that's really a very specific preventative intervention. And there are other examples. So moving from data to action. So we've done that screening. We understand somebody's overall health. Then what do we do? So we think about those screening modalities in terms of, well, is it going to change what we do for somebody in terms of their management? We take that information and we contextualize it. So we look at it in context of their family history and the other modalities that we've used. So there are biomarkers, there are imaging, there are lifestyle factors, there are genetics, and we come up with an overall picture. And then from there, we come up with proactive interventions so that we can mitigate risk or optimally treat illness to optimize their health going forward. So what are some of the things that we use? So outside of those lifestyle interventions that we had mentioned earlier, we can start to get into like medications, supplements, of which there's no shortage, but the challenge is separating out what is effective from what is not. Currently in the longevity medicine field, it's saturated. There are myriad supplements and vitamins and nutraceuticals, like foods that are promoted for their health benefits, along with other wellness and longevity modalities that are promoted as being healthy. So kind of segregating out or separating out what is effective from what is not is very important. Within longevity medicine, it's important for us as physicians to prioritize those interventions that have been validated with good science, and encourage people to utilize those interventions when they're applicable to their situation. But then we also think about those modalities or treatments or supplements that have not met that sort of randomized controlled trial standard. And there's a lot out there. It's hard to do a randomized controlled trial and really study something in a rigorous way so that you can say that this clearly is beneficial. They're just hard studies to do. So the situation that we end up in is one where we're looking at the theory or the mechanism underlying the potential benefit of an intervention and saying, does this make sense? Is it rational? Is it logical? And then we might look at some anecdotal evidence, and then we might look at observational studies. All of this is kind of circumstantial or not definitive, but if we're not thinking about these other modalities, then we're leaving a lot of potential benefit on the table. And it's important for us to weigh risk versus benefit, think about our patients individually, and then together, using some joint or shared decision-making between physician and patient in a very informed way, decide which of these other therapies are worthwhile. So another example, like in terms of, like when we talk about optimizing diagnoses or risk factors, some really good examples are thinking about blood pressure control. We really want to target blood pressures less than 120/80. We know that has an impact on people's wellness and longevity. Oftentimes that target is not hit for people, and people are allowed to run with blood pressures in the high 120s over mid 80s. From my perspective, that's not adequate blood pressure control. We need to be really aggressive about looking for metabolic syndrome and making sure that we're adequately helping people to address that, both with lifestyle interventions, but also introducing medications such as GLP-1s if they're appropriate, to help them optimize their metabolic condition, and then optimizing lipids like we had talked about earlier. When we talk about supplements, so there are supplements that have reasonable evidence, and I would say the list includes things like omega-3 fatty acids, vitamin D, magnesium, creatine, collagen peptides, and fiber. There are others, but these are the ones that hit the top of the list. Sort of some of the pharmacotherapies that we consider in the longevity medicine spectrum. Again, GLP-1s, metformin, PCSK9 inhibitors. So these are medications for really aggressive lipid management, hormone optimization. And then there's some talk about rapamycin, which is an immune suppressant used in a low-dose pulsed way, but that evidence is far from convincing. Things that really need better evidence that you probably hear about when we're talking about longevity medicine, things like NAD, IV infusions, stem cells, and peptides. BPC 157 is a good example. These really fall into that category of they make sense mechanistically, and there's anecdotal evidence, but we're lacking strong, like, human-based studies to say that they are effective and safe. And so these are things that are considered carefully in combination with a physician, and only used when clearly indicated under very particular circumstances. So back to kind of a longevity action plan and a framework. So it really starts with a baseline assessment, addressing fundamentals, mitigating risk, monitoring, iterating, changing the plan, and making sure you're partnering with a physician who's aligned with these goals. And that's it. I hope that was helpful. Let's see if there are any questions. All right. So I'm just going to run through. So lots I can't hear you. Sorry about that. All right. Sorry about the slides disappearing. I hope they came back. Would you recommend the Gallery test yearly? I would. For people 50 or older, I would recommend that annually. And can we get a copy of the slides emailed to us? Yes, for sure. If you want to just pop your email into the chat or email it to me at my email that's on the last slide there, alan.mottram@perennialwellness.io. I'm happy to give you the slides. And the presentation will be available on YouTube. It'll be posted there. So, all right. Well, thanks everybody. And definitely reach out to me if you have any questions. And if you want the slide deck, I'll send it right off to you. Thanks a lot. Bye-bye.